Okay. So looking at chapter 25, we're going to be talking about clients that have coronary and peripheral vessel issues going on. So, first thing, we need to learn what precludes having some issues. Well, the first thing we're going to talk about is arteriosclerosis. With arteriosclerosis, what you're looking at is this is actually calcium deposits. This doesn't have anything to do with cholesterol, okay? Calcium deposits tend to be what? Soft, hard, flexible, stiff, hard, right? So, and y'all know arteries and veins are supposed to what? Stretch and dilate and contract and do all that stuff. They need to be flexible. So when you've got a lot of this calcium deposit, what's going to happen to that flexibility? It's gone, right? Okay, it's not going to be able to dilate and contract. There's no elasticity left. So the ventricle is going to contract. And when this artery is rigid, it's not going to stretch. So that's going to reduce the amount of oxygenated blood that's going to get out to the body where it needs to go. That's vital organs, that's, your toes, your fingers, your feet, all that stuff. It's going to reduce a lot of that oxygenated blood flow. It's even going to reduce the amount of blood flow through your coronary arteries. If that heart muscle doesn't get oxygen, what's going to happen to it? It's going to have some ischemia, isn't it? Okay, possibly infarctions. Now, atherosclerosis is what we look at that is related to plaque buildup. Okay. And now both of these do lead to coronary artery disease, but we tend to concentrate more on the atherosclerosis because it does involve cholesterol plaque buildup, and we can kind of adjust that. We have modifying, lifestyle habits. We have medications now to help treat this. And what happens is when that plaque builds up in these artery walls, it makes these little ridges in the wall of the artery, so it's uneven and it's sticky. And we all know that we have blood clots floating around in our system naturally, right? Well, what happens is one of these blood clots hits one of these rough patches, sticky patches, and because that clot has hit that, it also initiates a clotting cascade. So now we got more clotting going on, and that clot's getting bigger. So this is how atherosclerosis will lead to heart attacks, strokes. If it blocks arteries to other organs like your kidneys, it can damage those. Okay. So, contributing factors. Well, it's fat formation and it's our metabolism. Patients that can develop atherosclerosis are going to be there's going to be a genetic factor. There's going to be obesity. A lot of it's lifestyle. Okay. I've known people that are about as big around as my finger that have high cholesterol. It wasn't necessarily due to being obese. It had to do with genetics and diet. If you eat a lot of saturated fats, then your lipid results are going to be all off the chart. And we're going to talk a little bit more specifically about those in a minute. Part of the atherosclerotic process also too is an inflammation process. There is inflammation that is involved. Risk factors for atherosclerosis, of course, is hyperlipidemia. Gender does play a role. Heredity, of course, we know diet does, right? Even diseases like metabolic syndrome. Metabolic syndrome is basically classified if the patient is obese, they have high blood pressure, their triglycerides are elevated, if their LDLs are low, HDLs are low, if blood glucose levels are not controlled, and if that is the metabolic syndrome. Okay. And of course, inactivity. We know exercise helps reduce your lipid levels. There has actually been, they have discovered that chlamydia pneumoniae can contribute to atherosclerosis. It does so because it can accelerate or destabilize the atherosclerotic process. And they know this because they have gone in with atherosclerosis. A lot of times you get these atheriomas, these little fatty spots in the artery wall. They've gone in and cultured those spots, and they came back positive with chlamydia pneumoniae. They even think other bacteria, like maybe the H. pylori, that has to do with developing gastric ulcers, may even be a contributing factor for atherosclerosis as well. Not been proven yet, but they're working on it. We could do actually see reactive protein on women. When they are elevated in women, it has been proven to be predictive of cardiac risk factors.
It says factors such as gender. Is it women that are more?
Men.
Men, okay.
10 to more. Women, their chances increase after menopause. Their risk after menopause are going to be about equivalent to that of men in the same age group. Body type also plays a risk into it. Patients that tend to be more apple-shaped, that means they carry a lot of belly fat, versus those patients that are pear-shaped, or population that's pear-shaped, that most of the weight's carried, below the torso. Those apple-shaped people are actually, that have been proven to be at higher risk for developing atherosclerosis. Of course, we know cigarette smoking also increases it. Diabetes, patients that are diabetic at 25% higher risk of developing atherosclerosis. And of course, patients that have high blood pressure is going to increase their risk. So, we now have this atherosclerosis, possibly some arteriosclerosis. So the major complication from this is a coronary occlusion. You're going to develop coronary artery disease from this arteriosclerosis process. And this can lead to occlusion. And when a coronary artery is occluded, the patient is going to have an myocardial infarction, a heart attack. Patients may not have any symptoms of any coronary artery blockages until there's at least a 60% occlusion. They may not even know. So, okay, patho and etiology, we already know. Arteriosclerosis, atherosclerosis. These all contribute to the process of coronary artery disease. Some inherited factors are, of course, going to be male, patients that are diabetic, patients that have increased lipid levels, genetic predisposition, high blood pressure. If they smoke, they don't exercise, they're overweight. People that tend to have that aggressive personality. Yep. High fat diets. Do you know, used to be back when, y'all remember when they said don't eat butter, you need to eat margarine? Now it's totally the opposite. Because margarine is nothing but saturated, hydrogenated fats. The butter is better for you, believe it or not. So when you're doing an assessment on your patient, what type of symptoms might you find? Well, they could be symptomatic if they haven't developed, a 60 or greater occlusion. They may complain of some fatigue. They may even say they have some chest pain. And it would be maybe possibly an angina type chest pain. And angina, the reason it is different from the type of chest pain that occurs with an MI is angina does not cause damage to the muscle. Okay?
It's like a tight pain.
Typically, it's a tightness, yes. It can radiate from the chest to the shoulders, from the left side of the chest, down the left arm to the fingertips. They may say there's some numbness and tingling. Some patients say it radiates at the left side of the neck to their jaw. Some say it radiates to the back between the shoulder blades. So there can be some varying symptoms. They may complain it feels like indigestion. Okay. A little different. A lot of your atypical symptoms, they put nausea in there because nausea usually follows the type of pain the patient is experiencing if he is having an MI. Angina does not usually cause nausea. Okay. But they may become nauseated. They may have some dizziness. And they may even say it feels like their chest is crushing or their throat feels like something's crushing their chest or their throat. If you look on page 384, there's different types of angina. Please be familiar with those, okay? So how do we diagnose our patient with CAD? Well, first thing we're going to do is a lipid profile. Okay, we're going to draw blood to see what their lipid levels are. And there's a table on page 386 that shows you the lipid levels. They can do a electron beam computed topography. I've never seen them go and do that for a patient to be diagnosed with CAD, but typically they can do a stress test. We can do a cardiac catheterization, which is the most definitive test to see which coronary arteries are occluded, and we can get a better the percentage, how much they're occluded with the cardiac catheterization. We can also do an arteriography, and of course, like I said before, stress testing. The ideal way we want to manage these patients, of course, is the weight loss if they're obese. Okay, if they have that aggressive personality, or they have a really stressful job or in a lifestyle environment, try to teach them some stress management skills, some coping skills. If they're diabetic, we want to keep that blood glucose levels under tight control, make sure they're maintained. Another thing we can do is give them nitrates, your beta blockers, your calcium channel blockers. These kind of help dilate and open up the arteries. If they're, diuretics may help to help reduce their blood pressure. And of course, the other drugs are going to help reduce their blood pressures as well. They have actually found that patients that will take folate or folic acid, vitamin B6 and B12, these are antioxidants, and it actually helps with the atherosclerosis. And we also have drugs now called statins. These are those lipid-lowering drugs. Patients, they may lose weight, but ideally, it may not reduce their lipid levels or the cholesterol levels, triglyceride levels. And if that's not working, then we can put them on the statin drug to help and decrease their lipid levels. Surgically, we can go in and actually open up those narrowed areas and try to push some of that plaque out of the way. One thing we can do is the angioplasty. or a balloon angioplasty, they go through the same procedures if the patient's having a cardiac catheterization. But on the end of that catheter is a balloon. And when they get to where that 60+% occlusion is in the coronary artery, they blow the balloon up and it presses the plaque back and it opens that area up more. We can go in and put stents in it. We can go in and scrape it out, what we call a roto-rooter job in the medical field. It's kind of like cleaning out, when your sink gets stopped up, what do? You get the little snake thing, or you pour some caustic stuff down in there. What you're doing is just going in and trying to remove it and open it back up. Bypass surgery is another option. That's usually going to be that's a very, very invasive and very drastic. These patients are typically going to have 90 to 100% inclusion in one or more coronary arteries when they go in and do the CABG. 90 or more in 2 or more coronary arteries. Or they may go ahead and do if they've already done the angioplasties, stents, and the patients are still occluding back up, then they'll go in and do a CABG as well. There's a new procedure they're doing. It's called a transmyocardial revascularization. These patients may not be candidates for CABG. That's an open, when you go in and do bypass surgery, that's an open heart surgery. They're cracking the chest open. They're stopping the heart. The patient's going on a heart-lung machine. Okay. Some patients may not be good candidates for this surgery because of other health issues or where to put them under anesthesia that allows them to not come out. Okay. So they've come up with this transmyocardial procedure, which is new. So let's look. I'll show y'all what the balloon angioplasties look like.
Or PTCA for short, is a minimally invasive procedure to open up blocked coronary arteries, allowing blood to circulate.
Welcome to Medical Videos. Here we are for supporting digital education. Take a good day.
Percutaneous transluminal coronary angioplasty, or PTCA for short, is a minimally invasive procedure to open up blocked coronary arteries, allowing blood to circulate unobstructed to the heart muscle. The procedure begins with the doctor injecting some local anesthesia into the groin area and putting a needle into the femoral artery, the blood vessel that runs down the leg. Once the needle is inserted, a guide wire is placed through the needle into the blood vessel. Following this step, the guide wire is left in the blood vessel and the needle is removed. An introducer is then placed over the guide wire, after which the wire is removed. A 35,000th inch guide wire is put in its place. Next, a diagnostic catheter, which is a long, narrow tube, is advanced through the introducer over the 0.035 inch guide wire into the blood vessel. This catheter is then guided to the aorta, and the guide wire is removed. Once the catheter is placed in the opening or ostium of one of the coronary arteries, the doctor injects dye and takes an X-ray. If a treatable blockage is noted, the first catheter is exchanged out over a 0.035 inch guide wire for a guiding catheter, after which the wire is removed. Once the guiding catheter is in place, a 14,000th inch guide wire is advanced across the blockage. Then, a balloon catheter is advanced to the blockage site. The balloon is inflated for a few seconds to compress the blockage against the artery wall. Then the balloon is deflated. The doctor may repeat this a few times, each time pumping up the balloon a little more to widen the passage for the blood to flow through. This treatment may be repeated at each blocked site in the coronary arteries. A device called a stent may be placed. A stent is a latticed metal scaffold that is placed within the coronary artery to keep the vessel open. Once the compression has been performed, contrast media is injected and an X-ray is taken to check for any change in the arteries. Following this, the catheter is removed and the procedure is completed.
So that's cardiac catheterization.
That is they go in just like they're doing a cardiac cath, and they're gonna do the cath and find the blockages. Then they're gonna do the balloon, possibly a stent placement, depends on the amount of blockage they have.
It's the same.
Same procedures, yeah. What's new nowadays, and I haven't researched yet to find out, is they actually now have because used to when a patient had a cardiac cath, ballonoplasty, stent placement, that whole procedure, when they're going in that femoral artery, used to, when they came back from the procedure, they had to lay flat for 8 hours. You didn't want to do anything to disturb that blood clot over that femoral artery. Sometimes we even put like a little, 5-pound sandbag on it, just to add that extra pressure. Nowadays, they're going through the wrist and doing it. So the patient is up and ambulatory, they don't have, when I say flat, I mean flat. They can't sit up or do anything that's gonna bend,
They got this little device now they put on there and help let the pressure off slowly.
Yeah. So, and that's a really good advancement because it cuts down the recovery time after the catheterization's done a lot. Makes the patients a lot happier too, because you know about some ill patients when they have to lay flat for 8 hours. They don't like that. All right, so for the TMR,
Transmyocardial laser revascularization, or TMR, is a surgical procedure for patients suffering from severe chest pain. Dr. Takushi Komodo is one of the cardiothoracic surgeons at UW Health who performs TMR.
Patients doesn't necessarily be in bad shape, but usually they have very bad chest pains because of the extent of the disease.
TMR offers an alternative treatment option when patients have advanced disease and the arteries cannot be stented or bypassed. The procedure is often done with coronary bypass surgery, but can be done alone.
We see the arteries of the heart. Then if any one of those are bypassable, that means we will do a bypass surgery. But if any one of the vessels are very diffusely diseased or calcified, and if we cannot do bypass, then we do a TMR to those vessels.
The procedure takes only 10 to 15 minutes. Using a computerized laser, the surgeon makes 1 millimeter holes or channels through the heart muscle of the left chamber of the heart.
The laser itself will stimulate the neoangiogenesis, meaning the growth of small vessels, as well as cause some denervation effect. So those are the two mechanisms of this procedure.
The denervation effect, which blocks the nerve and stops the conduction of pain, immediately relieves chest pain after surgery. So patients oftentimes start to feel better right after the procedure. Over time, growth of the new blood vessels improves the supply of blood to the heart. Though TMR does not improve overall survival, it is proven that TMR improves quality of life in each patient. Without chest pain, patients are able to engage in normal activity and exercise that was otherwise difficult or impossible. TMR is FDA approved. Several randomized clinical trials show the procedure can be beneficial to treat angina. Not all patients are candidates for TMR. You should consult with your cardiologist to see if the procedure is right for you.
it's pretty neat, isn't it? that are gonna have, that have CAD, you wanna always assess their chest pain, okay? And you know how to assess pain, right? When you're assessing chest pain, not only do you need them to give you a number, you're going to need them to describe it. Okay, what is the quality? Stabbing, crushing, is it pressure? You know, is it an ache? What? Does it radiate anywhere? These are going to be very important factors. We have patients that walk in, you have a patient that walks into the ER and they are complaining of severe epigastric pain that may or may not radiate, we treat them as if they are cardiac until we rule out, because you don't know. It's better safe than be sorry. Well, I've had patients come into the ER and they find out, okay, you just got really bad indigestion or, you know, something like that, because everything's come back negative, EKGs are fine, all the labs and cardiac enzymes are fine, and they're like so apologetic. I'm like, don't be apologetic. So I'd rather you come in here and be indigestion than you come in here or not come in here and then you die at the house of a heart attack. So. We want to encourage these patients to rest because they are going to be fatigued. They're going to be getting a lot of drugs that will help dilate, and some of these, especially your nitrate drugs like your nitroglycerin, it may cause them to be a little lightheaded and stuff when they initially take them. Oxygen is very important. Even if their O2 sats are staying above 90, we may still put them on about 1 or 2 liters of oxygen to kind of get them on up in the upper 90s up to 100%, because we want to make sure they are perfusing and that heart muscle is getting plenty of oxygen. That is our goal, is to save as much heart tissue as we can, or heart muscle, excuse me. We also wanted to educate them on what can they change, okay, to reduce their risk of or advancement of their CAD. Okay, quitting smoking, start exercising. You know, maybe we'll probably consult a dietitian, let them talk to them about proper diet, what foods they need to avoid, what foods are good to eat. It's very important, though, when we talk about exercising with these clients, that they do consult their doctor before they start an exercise program. It's not like they can just go walk in the gym and somebody work them up and, you know, they just go to pumping and doing aerobic, you know, exercises. You know, they may fall over dead. They are going to have to gradually build up. Okay. And of course, any diagnostic tests or treatment procedures they're going to be doing, yeah, you know, we know the doctors talk to them about it and get the paperwork signed, but what happens when the doctor walks out?
They ask you what's going on.
Yeah, they may not have understood everything, or then they think of a question, so guess who they're going to ask? It's the nurse, you. So you kind of need to be familiar with whatever procedures or treatments the patient's going to go through in case they have questions, and you'll be able to answer them accurately. And it's not, you know, I've done it with y'all. Y'all ask me a question, and I go, I don't know. Don't know everything. And it's okay to tell a patient, I don't know. I said, but I will find the answer for you, or I will find someone that has the answer for you. Okay. All right. Everything's not working good there. So now let's look at the MI. A patient that has CAD is progressed. Now our patient is having a heart attack. Okay. And the MI is when one of those coronary arteries has been occluded. That means that part of the muscle, depending on which coronary artery is obstructed, that area of the heart is now not getting oxygenated. The longer it goes without oxygen, the more damage and death to the heart muscle we will have. The patient typically, you're looking at transmural infarctions or subendocardial infarctions. With a transmural infarction, when y'all start learning tomorrow about EKGs, they're going to have a Q wave change. And the reason is because with this infarction, it involves the full thickness of that myocardial wall. not just the surface. Now, the subendocardial, there will not be any QA changes, and this does not extend through the full thickness of the muscle wall. It's only a partial thickness. And we already know the causes, right? Patient has atherosclerosis, arteriosclerosis, and a clot has occluded the narrowed area, or either a clot was moving through and the artery spasmed on it. Okay. Complications of MI, of course, are dysrhythmias. More than half of people that die from an MI usually do within the first 72 hours, and it's usually because of arrhythmias that occur. Because when you have death of heart muscle, what happens to that electrical conductivity that keeps the heart beating like it should? It stopped. I mean, you got dead muscle tissue. That electrical current isn't going to make that area of the heart contract, right? And so we start having a lot of these dysrhythmias. Cardiogenic shock is also another complication. When a patient goes into cardiogenic shock, this has a very high mortality rate. We usually see this in patients that have had significant damage to the left ventricle area. Patients can also have ventricular rupture that are having an MI. These patients will have sudden dyspnea. They will develop a very rapid onset of right heart failure, and they will go into cardiogenic shock. These patients, even if they are in a hospital that has a bypass surgeon, usually we can't get them to the OR faster. Your hemopericardium is another complication. That's basically where blood has accumulated in the pericardium, and the patient can develop a cardiac tamponade due to this. Usually when this happens with these patients, they do not have a very good prognosis either. And then, of course, our patients can have ventricular aneurysms. Some other complications are arterial embolus, where you've got clots that are going to form, usually in that area of that ventricular aneurysm, because the blood's going to pool there. Y'all remember what an aneurysm is, right? It's a weakening. So we're talking about a weakening in the wall of the ventricle. So there's a little bulging there. Well, what happens with that blood that's in that bulge? It kind of gets stasis develops. So guess what it's going to do? It's going to clot. They can develop venous thrombosis, that's blood clots in the lower extremities, the pelvis. And of course, we know that can lead to a pulmonary embolus, right? Pericarditis, that's where the pericardium is inflamed. Also, if there is enough damage to the area of the heart where the mitral valve is, it can damage those papillary muscles and cause a mitral insufficiency, so there tends to be some regurgitation. With men, they are typically going to present, they're going to complain of some sudden severe chest pain. It may be in the epigastric region, which is substernal. They may or may not complain that it radiates to the left shoulder, the left arm, all the way down. Like I said before, they may say it radiates up to the throat, up the jaw, to the teeth. Women tend to be more vague. They may just say, I'm really tired all the time lately. They may complain of abdominal pain, not epigastric. Epigastric is where? Substernal, it's like right here below the sternum. Abdominal pain tends to be a little bit lower, okay? Almost like it's like a small bowel, pain. And they may say they're a little short of breath. With this type of pain, what makes it different, anginal pain, patients can take their nitroglycerin and just sit down and rest, and it will go away. Unless they're having unstable angina. This type of pain does not go away when the patient sits down or lies back to rest. And if they do have nitroglycerin, maybe because they have coronary artery disease and been having some angina, the nitroglycerin is not going to make it go away. Okay. The biggest thing we can do when a patient comes into the ER, of course, we're going to, do a quick assessment, hook them up to the cardiac monitor. We're going to run whole blood. We're going to run cardiac enzymes, and most specifically the troponin levels. The troponin level is going to be the first indicator if it's elevated that patient is having an MI. The other cardiac enzymes that we run may not elevate till 2 to 4 hours out of having the MI. Like I said before, our biggest goal in treating our patients with cardiac issues is going to be what? Maintaining healthy heart. Maintaining as much healthy heart muscle as we can. So these patients that come in with an MI, we're going to be popping them with some morphine. That's our drug of choice for their cardiac pain because it dilates. We're going to put some oxygen on them. They're going to look at the EKG. Hopefully they're not having any dysrhythmias. If they're having dysrhythmias, we're going to have to treat them. The next ideal thing is to give them the thrombolytics. Y'all remember the thrombolytics from pharmacology? The TPA, streptokinase, those things that dissolve clots. So hopefully we give them those thrombolytics. It goes in there and it dissolves that clot that's blocking that coronary artery, and then we can get some blood flow back there. And that helps us reduce the damage. Okay. And then of course, not initially, but during their hospitalization, they are probably going to have a cardiac cath so we can see what arteries are blocked and how much the blockages are. And depending, on how much, they may go ahead and have the balloon therapy or a stent placement. Most of the time, these patients probably will eventually have a CABG. A lot of our patients that have MIs or have had bypass surgery, a lot of facilities now are offering what we call cardiac rehab. So we can get these patients back up, going, get their mobility back, get their energy levels back after the cardiac surgery or after the MI. And we call it a cardiac rehab program because it's usually respiratory therapists and or nurses that are monitoring the patients while they exercise. And it might be, start walking slowly on a treadmill, or it may be a stationary bike, type exercises.
What's the heart rate?
Don't know, I ain't never seen one. I've never heard of it. And of course, like I said, you want to get a good assessment of their pain. It's going to be very important. We know we're going to monitor vital signs, right? Always going to monitor their cardiac rhythm. Why would we monitor their lung sound? If they start developing heart failure because of it, they're going to get what? Pulmonary edema. You also want to monitor their peripheral pulses. Make sure they're not throwing those clots, and blocking any peripheral arteries. For our acute acute pain, of course, we're gonna give oxygen, because if we can get more oxygen going to that heart tissue, it's gonna help the pain. Of course, we're gonna give IV morphine. We're gonna give nitroglycerin. Some of these patients, we actually put on nitroglycerin drips, okay, to help maintain their pain. IV morphine is really good, but guess what? It is what? A central nervous system depressant. So we can only give so much before we're gonna have our patient knocked unconscious, right? Or we're gonna have their blood pressure down on the floor down there. Of course, these patients are gonna be anxious, they're gonna be scared, okay? If they're having severe enough chest pain with the nausea, the vomiting, the shortness of breath, these patients will actually have that feeling of impending doom. And they'll tell you, you try to calm them down, they're like, no, it's not gonna be all right, I'm gonna die. And they will tell you that, they feel it. So it's very important that we explain everything to them. Okay. The doctors will probably order, it's not unusual to have them on like Ativan or Xanax, an anti-anxiety drug, to kind of help with that. We do try to keep the environment quiet. We try to limit visitation in some patients. It just depends on the patient's condition. ICU back in the day used to be only immediate family. You could only come in at certain hours for the first few minutes of that hour to visit. They don't do that anymore. They realize that causes the patient more anxiety. Family members at the bedside are usually their comfort factor. So they're not really strict about that anymore. Unless they have to go in and do something with the patient and then they'll ask the family to step out. They don't restrict it to 2 visitors at a time anymore. It doesn't even have to be immediate family, anybody can go in. So, that's a good thing. Any questions on MIs? No questions? Y'all want a 10-minute break? Wake up, y'all look like I'm going to sleep.
How do you after the damage has already occurred? Is there any way to improve?
That tissue does not regenerate. That's one thing about kidneys, heart, and brain. When the tissue is damaged, it does not regenerate. And nerves. They don't.
That's what I thought, but like my uncle, they're trying to lower his blood pressure a lot because they said that when you lower it, it allows the heart to somehow, and now I wasn't there for that doctor's visit, but slowly repair some things.
If he has ischemia,
Okay.
yeah, if there's ischemia, it can regenerate because it's not dead.
Okay, that makes more sense.
Yeah, it's not dead. If it's infarcted, it is dead. Once it's dead, it does not regenerate. And that's why we have a lot of our MI patients that they will eventually develop left-sided or right-sided heart failure, depending on where the damage is.
Will they, or if it's bad enough after they've had it in, could they possibly be on transplants? Or is
Yes. If there's enough damage, yeah. I had a good friend of mine, her mother-in-law, wasn't her mother-in-law at the time. She actually came in and she probably had not been admitted to the ICU, but about 2 or 3 hours, and she arrested. And we did everything we know to do. We pulled out every drug you could name, everything we could do. And her doctor at the time, was like, what else can we do? And we were just like at a loss. So we said, get her to Savannah. And he rode in the ambulance with her to Savannah. They got her to Savannah. They put her on the balloon pump that we talked about yesterday that kept her heart pumping while she got on a transplant list and got a new heart. And she lived probably about 25 years. Just died recently. drape or not? Oh, you do? Okay. See, I don't even know how many slides is on here. I read through them, I don't pay attention to numbers. All right, so peripheral blood vessels. All right, we know what PVD is. We talked about that a little bit yesterday, right, in relation to DVTs. There are some other conditions that you may run across. One is Raynaud's disease. These patients usually under stress or extreme temperature drops, and you see it most commonly in the hands. The patient's blood vessels will actually, the arteries will actually constrict. And you will actually see their fingers. It can be just the tips, or it can actually go on down into the hands. They will turn a purplish blue because of lack of circulation, and it hurts too. When we're looking at PAD, which is peripheral arterial disease, that's where I talked a little bit about yesterday. The patients, if they have peripheral arterial disease, they're going to have a shiny look to their skin on the lower legs. There's not going to be a whole lot of hair. You're going to have decreased pulses. Of course, we know we can develop blood clots in the lower extremities. Excuse me. And believe it or not, men actually have more increased incidence of peripheral arterial disease than women do. Women tend to have more of the DVT, the deep vein thrombosis, but men are more prone to PAD with arteries versus veins. So what can happen? Well, there's decreased arterial flow, so that means no oxygen. So what's going to happen with that extremity? What's it going to start looking like?
Gangrene.
Yeah, it's going to start looking cyanotic. You're going to have decreased capillary refills. You're going to have decreased pulses. And it's going to develop, it's going to keep progressing and developing the gangrene. They can actually even develop some open sores. And of course, they're not going to heal very well because there's no arterial circulation. These patients usually do have to have the limb amputated. So Raynaud's, like I said, this is a spasm of the arteries and arterioles in the fingers. It can happen in the toes, nose, ears, and even in the chin. The only instances I have ever encountered with it has been in the hands, the fingers. So these patients, like I said, because there's decreased circulation, it's going to be numbness, tingliness. They're going to have some stiffness. It's going to be hard to move. They're going to have those fine motor skills. Once they become that purplish blue color I talked about, that's when they're going to really start to ache and to hurt. Okay? And the ideal thing, and like I said, this is usually in response to cold temperatures. So our ideal thing is if we can get them warmed back up, those spasms in the arteries and arterioles will hopefully relax and we can get some circulation back in. Okay. Patients that have this in the extreme condition, they can eventually develop some ischemia in the tips and also some paresthesias where they're losing some of the feeling. One nurse I worked with one time, she had it so bad she came in and she wore like double insulated gloves, but when she came in that morning and she pulled her gloves off, her hands were very deep and a good, and a purple, blue, almost a black on the tips. Yeah, that is the worst case I have ever seen. So what can we do? Well, big thing is avoid anything that precipitates the attacks. Quit smoking, because nicotine does what? Constricts. We can treat them with vasodilators. Okay. Help keep those arteries and arterioles open. And of course, if they've developed any gangrene, we have to go in and amputate. Because it's just gonna continue to progress upward if we don't. Warming the hands is a good thing. And also educating, is gonna be very important. Some of these patients need to know that even indoors, they may, especially during the winter time of the year, they may need to wear gloves even when they're indoors to keep them warm and keep from precipitating an attack. They can do other things to help restore circulation, doing this, just swinging your hands up and down, that can kind of help restore some circulation. So there's different things that we can educate them on. So, thrombophlebitis, we know what this is, right? Why your book has it in the previous chapter in here, I don't know. Do I need to go back over it? No? Okay. I think one, we know how to manage it, right? We know what surgical thrombectomy. We know what, that Holman sign thing right there, we don't really do that anymore. Varicose veins. Everybody's seen varicose veins, haven't you? Okay. Where can varicosities occur? Legs and
Arms. Since more than the arms.
rectum.
Oh, yeah.
Hemorrhoids. That's what hemorrhoids are. They're varicose veins in the rectum. That's all they are. So, basically what you're looking here, it's kind of like what I talked about, how some patients are at risk for DVT. A lot of those patients also have the valves in the veins. You got to remember, when you're up and moving, your muscles are contracting, they're compressing the veins, they're pushing the blood back up, and there's valves in the veins to keep the blood from going back down. Okay, make sense? So when those valves start breaking down and they're not closing all the way, then you're going to have, the veins are going to start getting engorged and they're going to stretch, and then that's what develops into the varicosities. Okay. We see this a lot from patients that are standing on their feet in one place. People say a lot of nurses have them, not necessarily because we don't stand in one place. Okay, we usually need roller skates to get around. Because when we're moving, the muscles are working and they're pushing the blood back up. Okay. When the person is standing still in one place, then you don't have the muscle contraction, so you've got more pooling and you've got more breakdown of those valves. Okay. Obesity does add to it as well because of the pressure. We see it develop in some of our pregnant women because of the pressure of the baby in the pelvic area. If patients have enlarged liver or abdominal tumor, those again, they're adding pressure. The patients are going to say that their legs kind of feel heavy, their legs get tired very quickly. They may say when they start moving around or they can elevate the legs, it makes them feel better. Of course, the big indications, we're going to look at them and what? They're going to be nice, fat, and swollen. Okay. They're going to look kind of a bluish, purplish, greenish color. They're gonna, your book says snakes. I always thought about earthworms when I look at them. So that's the biggest thing. What can we do for them? Well, prevention is the best thing. Okay, that is if you have a patient that they're kind of, they're stationary and on their feet a lot, tell them they need to move around. They don't need to stand in one place and lock their knees. Support hose are very good. When I was pregnant with my first child, the first thing I went and got, just to make my legs feel better, if nothing else, was a pair of thigh-high Ted hose. And it did, it made a big difference, made my legs feel a lot you didn't have all that constriction around the baby, like you do with support hose. I don't know about y'all, but I hate some support hose. They can go in if they're severe enough, and for cosmetic reasons, typically, they'll go in and do what we call a ligation or a stripping. The stripping is typically an old treatment now. They actually can go in and inject the veins with a caustic agent that will cause them to shrink up. Stripping nowadays is more, and the ligation is more of a last-ditch effort. Chemical treatment works usually a lot better. And like I said, most women choose to have it done for cosmetic reasons more than anything. With these patients, always make sure you assess circulation. Always check for edema, and make sure you educate them on layering the anti-embolic devices or support hose. And they can actually get support hose nowadays that aren't necessarily TED hose, that come up like to the knees if they have them in their lower calves. Most people are going to develop them from like the back of the knee down. It's typically where you see most of them, but they can start developing in the upper thigh area. All right, we know what an aneurysm is, right? That's that bulging. There's a weak in the arterial. There is a weak area in the arterial wall because of the bulging and the stretching. This is usually accompanied with patients that have arteriosclerosis, patients that maybe they have hypertension on top of it. It can also be due to some trauma that has occurred, or it could be a congenital defect. They're maybe born with it. A lot of times with aneurysms, the patient does not have any symptoms. They have no idea they even have one. What type of aneurysm it is going to depend on where is it at. Aneurysms can occur in the brain, where they rupture and cause a stroke. Okay. They can occur on the aorta itself, and we call it an aortic aneurysm. So there's different places where they can occur. We already know about the ventricular aneurysm, right? So there's wherever they occur is going to depend on what symptoms you're going to see. Like I said, initially they're going to be asymptomatic, but when it starts leaking or if it suddenly ruptures, depending on where it's at, depends on what the symptoms they're going to have. We know that if a patient has an aneurysm in the brain and it ruptures and they start bleeding in the brain, what are going to be your symptoms? Decreased consciousness? Yeah, because there's nowhere for that blood to go and it starts pressing onto the brain tissue. Okay. If it is in the aorta and it ruptures, what's going to happen? The patient's going to complain of very sudden chest pain. It could be upper abdominal, sternal chest pain. And they're going to start becoming unconscious very quickly because it's a massive blood loss. So just watch your patients for any massive hemorrhaging, pain, any discomfort, or any symptoms that, can tell you, okay, they must be having some pressure buildup because the blood's building up. They're having pressure against other organs or other areas. Okay. Usually if a patient is diagnosed with an aneurysm, they will follow this patient closely. They'll watch this, they'll actually measure it and keep up with the size of it, make sure it's not getting bigger, and try to monitor the patient so that when it gets to a certain size, they'll go in and do some surgical corrective procedures to prevent it from rupturing, ideally. A big thing here, of course, in helping with reduce the risk of the aneurysms getting bigger or rupturing is, of course, keeping their blood pressure down. That puts less stress on that aneurysm. They can go in and bypass the aneurysm or actually go in and graft it. patients should be taught, some stress management, okay, minimal activity. They don't want to strain during bowel movements because that increases pressure where? In the brain. Mhm. Coughing, they're holding their breath when they're changing positions and stuff. This all increases into cranial pressure. So if they have an aneurysm in the brain, these instructions will help reduce that increase in cranial pressure. And of course, we want to monitor when they're in the hospital, their vital signs, their intake and output, and always monitor their color and the skin's temperature. Okay. Any questions?